Hey, this is Sketchy. We're a learning company, and this podcast is a review of the material meant to be used in tandem with our videos, quizzes, and Symbol Explorer to help the lessons stick. Or use this to passively review a topic while you're on the go. Check out the link in the episode bio to watch the video that goes with this podcast. All right, let's get started.
Lyme disease is the most common insect-borne disease in the United States. Ha! Suck it, malaria. If left undetected and untreated, it causes 3 stages of disease. So this video will help you become a Lyme recognizing and diagnosing mastermind. Because it's caused by the woods-loving deer tick, Ixodes scapularis, what better place to explore it than with Robin of Ixodes and his merry peoples in Sherwood Forest? However, we won't be in England. No, this Sherwood Forest is located on Cape Cod, that silly little phallus of Massachusetts where vacation-starved New Englanders cram themselves every summer. And if the sharks don't get them, Lyme disease will. Lyme disease is actually caused by the spirochete Borrelia burgdorferi. As I mentioned, these disgusting little motile spiral-shaped bacteria are jammed into humans by the evolutionarily completely friggin' useless Ixodes scapularis. Here's what they look like. From left to right, this is an adult female, male, and nymph. The nymphs are classically compared to poppy seeds in size. I know you can't imagine not noticing that one of these suckers has buried its head in your dermis, but actually, many people will present with signs and symptoms of infection without recalling a tick bite. Often, the tiny devils attach where the sun don't shine and, after transmitting Lyme, fall off and go their merry, creepy way in search of more dermis. I understand that you want to pause the video now and go shower for 45 minutes using a cheese grater as a loofah. Don't worry, we'll wait. All clean? Great. Now let's see where you might be able to become an unwilling and unwitting host for these poppy seeds of Satan's bagel. This map shows where Lyme disease is most prevalent in the US. As you can see, it's mostly in the Northeast and Upper Midwest, but there are also cases scattered across the country. So even if you're in part of the country that isn't bathed in ticks like the Northeast, remember to ask about travel history, including Europe and Asia. And ask patients to leave their suitcase outside the exam room. This sign will help you remember that deer ticks are the most likely to throw crazy towny kegas in the Northeast. Wicked pissa. Okay, now we know where patients get it, but how will they present? Well, as we mentioned, infection can cause 3 stages of disease which present and are managed differently, so we'll cover each in detail. Stage 1 is called early localized disease. It occurs in the first 30 days after infectious transmission. It can cause malaise, fever, chills, and myalgias. So suspect stage 1 Lyme if a patient presents with a flu-like illness in summer. But be aware that flu and Lyme infections overlap in the spring and fall. But the pathognomonic sign of stage 1 Lyme disease is the infamous erythema migrans, or EM, rash, which appears in about 80% of patients. It's a rounded red area that often, but not always, starts at the site of the tick bite. It's usually painless and rarely itchy. Note that many patients will have a local erythematous reaction to the tick bite itself. You can differentiate this from true EM because EM gradually expands or migrates beyond 5 centimeters in diameter over the course of several days. An important note, EM only sometimes has a central clearing, causing the classic bullseye appearance. Most often, it's diffusely erythematous. Let's check out a few examples. EM is often found in or near the axilla, inguinal region, popliteal fossa, hairline, or belt line. So make your patient get naked, don the goofy gown, and check everywhere. Studies have shown an underdiagnosis of stage 1 and higher rates of disseminated Lyme in patients with darker skin tones. This is due, in part, to physicians lacking training detecting the diverse appearance of erythema migrans. Here you see EM on the thigh of a pale patient where it looks pink, and then in the axilla and popliteal fossa of patients with darker skin where it appears darker than the surrounding skin. But implicit bias can also lead providers to omit Lyme disease from the differential for patients of color. When considering Lyme, our culture leads us to conjure mental images of a pale white UMass student named Scooby Hikerton who climbs Mount Tom in a pair of Birkenstocks to smoke a doobie on the summit. But I live near UMass and trust me, people of all skin tones climb Mount Tom to smoke a doobie. Okay, grab a stress ball, because we're going to cover diagnostics for stage 1 Lyme disease. While there are serologic tests for antibodies to Lyme, they're not very helpful in stage 1 because they don't become positive until several weeks after infection. So you'll have to rely on the history and physical like it's 1842. So if a patient with a history of tick exposure presents with an obvious EM rash, you should leave clinic immediately and play the lottery because you just hit the easy diagnosis jackpot. Call in some antibiotics on the way though. You're not an animal. However, if your patient has been in a Lyme endemic area and has nonspecific flu-like illness but no EM, then let your nurse know that the rest of your clinic is going to run even later than usual because you need to discuss the complex pros and cons of 2 possible approaches with your anxious patient. The first is watchful waiting, during which the patient watches for EM like a hawk that can somehow hold mirrors at various angles, and you order serologic testing for 2 and 4 weeks after symptom onset. If the patient develops EM and/or the tests are positive, then treat them. The other option is empiric treatment after discussing the risks of taking unnecessary antibiotics. In this case, you will not order testing because the antibiotics may prevent seroconversion, which means that the patient would never know if they actually had Lyme disease. Damn you, Ixodes! Check out the differential diagnoses menu for stage 1 Lyme disease. For the general symptoms, these include influenza, COVID-19, as well as other tick-borne diseases like anaplasmosis and babesiosis, which can both co-occur with Lyme. The differential for erythema migrans includes cellulitis, nummular eczema, insect bite hypersensitivity, tinea corporis, and granuloma annulare. Treatment for stage 1 Lyme is doxycycline, represented by the bicycle wheel, for 14 days. You may recall from sketchy pharmacology that tetracyclines are represented by bicycles. But if your patient is less than 8 years old, pregnant, or allergic to doxy, then use amoxicillin for 14 days. It's important to remind patients to wear sunscreen because oral doxycycline causes photosensitivity on par with topical Crisco. Seriously, people get roasted. Okay, if stage 1 Lyme is not caught and treated, patients may present with stage 2 or early disseminated Lyme disease. The onset is usually 1 to 3 months after infection. Patients can present with multiple EMs which can occur anywhere on the body, not just at the site of the tick bite. While there may be general symptoms like malaise, the main symptoms relate to the specific organ system those little spirochete wankers have attacked. Myalgias and arthralgias are common symptoms of the musculoskeletal system. The arthralgias are migratory, affecting various joints. The first episode usually lasts a week, and if untreated, can recur every few months, which really puts a damper on evading the authorities after robbing the rich. Lyme infection can also reach the heart. Lyme carditis can cause myopericarditis or conduction abnormalities, most commonly atrioventricular block ranging from 1st to 3rd degree. Patients usually present with palpitations, but may also report chest pain, dyspnea, dizziness, and syncope. Yes, ticks can literally break your heart. When Lyme disease attacks the nervous system, it's called neuroborreliosis, unless you actually have neuroborreliosis, in which case you'll probably call it, "He has tick brain. Why?" It can attack the peripheral or central nervous systems. Peripherally, cranial neuropathies are the most common presentation, especially facial or 7th nerve palsy, known to many lay people as Bell's palsy, but we know it's only called that if it's idiopathic. Although it's perhaps best known by lay people as, "Hey, what's the matter with your face?" Note that 7th nerve palsy due to Lyme can be bilateral. Lyme radiculoneuritis, which is more common outside the US, causes significant pain as well as sensory and possibly motor changes along one or more dermatomes in the trunk or limbs. This is probably the most commonly missed manifestation because it can mimic mechanical radiculopathy. The most common central nervous system manifestation is Lyme meningitis. It can present like any meningitis with headache, fever, neck stiffness, and photophobia. However, it tends to have a more gradual onset than viral or bacterial meningitis, with a waxing and waning headache. It's also more likely to be accompanied by peripheral neuropathies. Lyme can also cause encephalomyelitis, which resembles multiple sclerosis, but it's so rare in the US that you're more likely to be hit by a bus on a boardwalk, flung into the ocean where you're eaten by a shark, which is subsequently struck by lightning, twice. Okay, let's examine the patient. On physical exam, you may note fever and lymphadenopathy. Do a thorough skin exam for EM rashes. Painful joints may exhibit mild swelling. Cardiac exam may reveal irregular rate and rhythm. Myocarditis or pericarditis can cause extra sounds like a cardiac rub, S3 and/or S4. Also, do a complete neuro exam to assess for signs of meningitis, such as nuchal rigidity and papilledema. Check for cranial neuropathies, especially of the facial nerve with weakness or paralysis of facial muscles, and assess peripheral nerves for sensory, motor, or reflex changes. It's time to bust out the netter for that sweet, sweet rainbow dermatome page. Oh, netter, you clever bastard. In stage 2 or early disseminated Lyme, lab testing actually becomes an option. Yay! It's a 2-step process. The first, an enzyme immunoassay, or EIA, screens for IgM and IgG antibodies directed against Borrelia burgdorferi. If this is positive, the second step, a Western blot or another EIA, check for IgG to confirm the diagnosis. You would think that this would wrap up your diagnosis in a nice little package. You might also think that toddlers with puppies should go door to door handing out free chocolate chip cookies, but that just isn't the world we live in. In our world, Lyme testing is rife with false positives and false negatives. And the only people going door to door want you to subscribe to magazines like Needlepoint Nudes and Deer Hunting Debutante. Lyme disease is primarily clinically diagnosed with serologic testing used only for confirmation. As in stage 1, you should not test a patient who has obvious EM because a false negative result will only confuse the situation and the patient. And due to the risk of false positives, you need to have a high index of suspicion for Lyme before you order the test. Therefore, you should not test a patient with vague symptoms that are not specific Lyme manifestations. False positives can be due to antibodies to other bacteria cross-reacting with the Lyme test, or because the patient was exposed to Lyme in the past, whether or not they developed disease and were treated at that time. Patients in endemic areas can develop antibodies to Lyme without knowing it. So really, the only time to test a patient is if they were in an endemic area and have signs and symptoms highly suspicious for disseminated Lyme, but no EM. It's important to ask about possible signs and symptoms of stage 1 Lyme that the patient may have ignored or dismissed to help establish your pretest probability. If a patient presents with meningitis and they were in a Lyme endemic region in the previous few months, Lyme should be high on the differential. As a part of a routine workup, a lumbar puncture will be performed. Now, if CSF evaluation rules out other causes, you can actually diagnose Lyme meningitis using high pretest probability, the clinical picture, and serum testing for Lyme antibodies. However, if you're worried about serum seropositivity being from past infection, you can test the CSF directly for Lyme antibodies. But because serum antibodies can cross into the CSF is only considered truly positive if the antibodies there are at a higher concentration than in serum. But beware, CSF antibodies can be undetectable in Lyme meningitis, so a negative result does not rule it out. I know, you want to drop an F-bomb, but you're in a library. May we suggest creating a small spirochete effigy out of notebook paper which you can burn later in the parking lot? Perhaps even urinate on it to put it out? We found that immensely satisfying, and then had to move our offices due to complaints from local businesses. You may be wondering about imaging. Well, stop wondering, because it will be normal with Lyme disease, unless the patient has encephalomyelitis. But again, you won't see that because you've been eaten by a shark. There are a bunch of other tests that have been explored for Lyme, like culture, PCR, and urine antigen tests. But they're about as useful as a wool condom knitted by a drunken donkey, so don't order them. And a pox on companies that market them directly to patients. I'd also like to request a pox on companies that use non-CDC approved interpretations of serology testing because they erroneously overdiagnose patients. Early disseminated Lyme disease has its own differential diagnosis list, so be sure to check out the DDX menu. Neurologic manifestations of Lyme can resemble stroke, Guillain-Barré syndrome, nervous system tumors, sarcoidosis, mechanical radiculopathy, e.g. sciatica, and all possible causes of meningitis, including neurosyphilis, which is, not incidentally, another spirochete. For carditis, consider infectious or autoimmune carditis such as parvovirus B19, human herpes virus 6, syphilis, and sarcoidosis, as well as MI. The treatment for early disseminated stage 2 Lyme depends on the manifestations. If the patient only has mild illness with EM or isolated 7th cranial nerve palsy, treat with oral doxy or amoxicillin for 2 to 3 weeks. Patients with symptomatic carditis, e.g. chest pain, syncope, and dyspnea, should be hospitalized for IV ceftriaxone initially and cardiac monitoring with temporary pacemaker for complete heart block. Lyme meningitis also warrants IV ceftriaxone initially. Once symptoms have improved in meningitis and carditis, the patient can be switched to oral doxycycline to complete a 28-day course. Sometimes a patient does not present until many months to a few years after B. burgdorferi transmission, at which point they have late or stage 3 Lyme disease. The hallmark of this stage is Lyme arthritis. It tends to affect large joints, with the knee being the most common. Although there is significant swelling, it's not usually very painful. So patients can present after weeks of persistent or intermittent swelling, especially if they're healthcare professionals, because we're busy and have been trained to ignore our own suffering. But don't do it! Instead, help contribute to a new culture of healthy, happy, and therefore astute and compassionate doctors by taking good care of yourself. The cause of neurocognitive symptoms in stage 3 Lyme is controversial. Patients may report chronic, mild to moderately impaired memory and concentration, insomnia, fatigue, and mood symptoms like irritability and depression. These general findings are referred to as encephalopathy, unless specific findings of CNS infection is found, in which case a diagnosis of subacute encephalitis is made. True Lyme encephalitis is considered rare. Most encephalopathic symptoms are thought to be due to the physiologic, inflammatory, and psychologic stress of having late Lyme rather than a true CNS infection. More on this later. On exam, Lyme arthritis causes warmth and significant diffusion which can restrict the joint's range of motion. There are usually no objective neurologic findings for encephalopathy. Lyme arthritis is diagnosed by clinical history and exam as well as positive serum antibody testing. Joint aspiration for synovial fluid analysis is done to rule out other causes, especially septic arthritis. Because Lyme encephalitis is rare and symptoms of encephalopathy are vague and commonly due to other factors, the diagnosis of late CNS Lyme infection requires multiple steps to avoid overdiagnosis. First, formal neuropsychiatric testing can help you decide if there's a significant objective dysfunction. You must also establish a high pre-test probability of Lyme by eliciting a history of possible tick exposure and past Lyme signs or symptoms. Only then can you consider serology testing. If both steps are positive, you can consider making the diagnosis of Lyme encephalopathy. Positive CSF Lyme antibodies will help support a diagnosis of Lyme encephalitis. Because so many harried, modern, overworked, smartphone-toting Americans with terrible diets and no regular exercise suffer from the vague, nonspecific symptoms we just described, all of these steps are necessary to prevent the overdiagnosis and overtreatment of stage 3 neuroborreliosis. Heck, I myself am feeling a hankering for some easy fix doxycycline right about now. Check out the differential diagnoses menu for late Lyme to learn the thrilling details about things that act like Lyme arthritis, including septic arthritis, gout or pseudogout, popliteal, Baker's cyst, reactive arthritis, and rheumatologic crap like lupus and RA. Copycats of Lyme encephalopathy include fibromyalgia, chronic fatigue syndrome, post-Lyme syndrome, more on that later, Alzheimer's, depression, neurosyphilis, attending medical school or residency, and parenthood. Lyme arthritis warrants 28 days of oral doxycycline or amoxicillin. Lyme encephalopathy or encephalitis needs 28 days of IV ceftriaxone. Now that we've discussed all the stages of Lyme and how to treat it, we unfortunately have to dangle you over the snake pit of post-treatment Lyme disease syndrome, or WTF for short. About 10% of patients who are appropriately treated for Lyme disease develop nonspecific symptoms such as fatigue, diffuse musculoskeletal pain, and cognitive difficulties lasting months to years. The etiology of this syndrome is unclear, and opposing theories have caused everything from uncomfortable office visits to family brawls at New England barbecues. The two main camps that have squared off, a la Yosemite Sam and Bugs Bunny, are the International Lyme and Associated Disease Society, aka ILADS, and the Infectious Disease Society of America, aka IDSA. ILADS leans towards blaming persistent infection with Borrelia burgdorferi and therefore recommends retreating with prolonged antibiotics, often for many months. Their treatment guideline admits that this is based on, quote, very low quality evidence, unquote. In contrast, the IDSA maintains that there is no evidence to support the theory of persistent infection, but clear evidence that retreatment with antibiotics is not beneficial and could actually be harmful due to side effects and secondary infections with resistant organisms. Luckily, most post-treatment symptoms self-resolve over 6 to 12 months, and if not, they're most likely due to other etiologies which should be sought out and managed. And now that you realize what a crap circus diagnosing and treating Lyme can be, I bet you're hoping that there's a way to just prevent it. Well, there is. The first step is to avoid tick attachment. This is done best by never leaving the house and having no outdoor pets. If your patients insist on leaving the house, then they're supposed to dip themselves in DEET and wear long pants tucked into their socks. So when you visit New England, you'll now understand why the woods appear to be full of odd-smelling Urkel impersonators. And finally, at the end of every tick-infested day, New Englanders strip down and inspect each other's every crack and crevice for ticks, armed with tweezers and a strong stomach. But let's be honest, those little bastards can't really be stopped by pants, socks, DEET, semi-automatic weapons, or hand grenades. There was actually a recent JAMA article on the efficacy of hand grenades in Lyme prevention. P was sadly greater than 0.05, and several researchers are now fingerless. So when your patient inevitably comes in with a tick bite, there's one final option for prevention, and that's antibiotic prophylaxis with doxycycline. But there's a list of strict criteria from the IDSA that must be met. And trust me, you do not want to mess with them, lest you wake up with a tick head on your pillow. Number 1, the tick is an Ixodes scapularis. Number 2, the tick was attached for at least 36 hours, which is about how long it takes to transmit Lyme. Or if the patient isn't sure about timing, the tick is very engorged. Ugh. Number 3, the local rate of infection is at least 20%. And number 4, the patient takes the doxycycline dose within 72 hours of tick removal. Okay, now you're a Lyme expert. Let's do a quick review, because all this talk of woods is probably making you antsy for a DEET dip and a hearty socks-in-your-pants hike. Lyme disease is caused by the spirochete Borrelia burgdorferi, transmitted by the deer tick Ixodes scapularis, most commonly in New England and the upper Midwest, as well as Europe and Asia. Stage 1, or early localized Lyme disease, occurs within 30 days of infection, presents with flu-like symptoms, and can only be definitively diagnosed by the pathognomonic erythema migrans rash. For the 20% of patients without a rash, you can treat empirically or check two-step serology at 2 and 4 weeks after symptom onset, because antibodies will not show up until then. Treat stage 1 Lyme with 14 days of oral doxycycline or amoxicillin. Stage 2, or early disseminated Lyme, presents 1 to 3 months after infection and can present with fever, multiple EM rashes, myalgias, and arthralgias. Lyme carditis most commonly causes AV block, or less commonly, myopericarditis. Stage 2 can also present as neuroborreliosis. The most common peripheral presentation is 7th cranial nerve palsy. The most common CNS manifestation is meningitis. A clinical diagnosis of stage 2 Lyme disease can be supported with two-step serology testing, which should only be ordered if the patient has been in a Lyme endemic area and has signs and symptoms that are very specific to Lyme disease. Treat mild stage 2 Lyme with 2 to 3 weeks of PO doxycycline or amoxicillin. Patients with Lyme carditis and meningitis start with IV ceftriaxone and need 28 days of antibiotics. Stage 3, or late Lyme disease, presents months to years after infection and usually presents as arthritis with swelling of large joints, particularly the knees. The mild to moderate cognitive symptoms of Lyme encephalopathy are usually not due to direct CNS infection. Like stage 2, diagnosis of stage 3 Lyme disease is based on a highly suspicious H&P plus two-step serology testing. Lyme arthritis resolves with 28 days of oral doxycycline or amoxicillin. Late neurologic Lyme disease is treated with 28 days of IV ceftriaxone. Lyme disease can be prevented by avoiding ticks. But if a patient from a high transmission area presents within 72 hours of removing an engorged Ixodes scapularis tick bite that lasted at least 36 hours, you can offer a prophylactic doxycycline dose and a cheese grater for their next shower.
Check out our other topics on YouTube or go to sketchy.com for our full suite of MCAT and med school lessons. Thanks for listening and stay sketchy out there.